throughout the webinar. Please feel free to enter any questions in the Q&A. Again, you can find that in the More section at the bottom of your screen if it doesn't say Q&A right there on the front page. If you're having technical difficulties, as we all do sometimes, please try to re-log in or update your Zoom. Worst case, reboot the computer. We'll still be here when you get back. And if you have really specific questions, go ahead and drop them into the Q&A section, and our facilitators will try to help navigate any of the technical difficulties. If we have time, we will facilitate a Q&A. Otherwise, we will invite the speakers to share their answers later on. And then we will also allow people to share questions. Boy, I got off script there for a second, sorry. After, we will send out a survey to you, and it will be an opportunity to ask further questions if we don't have a Q&A session because of time. So you will be able to ask questions and get answers if we run out of time. And then please always follow us on our social media, stay connected with ICHS, find out about all the important work and exciting happenings through our e-newsletter that we are sending out quarterly. We'll send a survey out at the end, as I said. And now, without any further ado, I am going to take the great pleasure to introduce the ICHS CEO, Chief Executive Officer, Kelli Nomura.
Thank you, Melissa. Welcome, everyone. I'm Kelli Nomura, CEO of International Community Health Services, and thank you all so much for joining us today. It's wonderful to see some familiar faces on this call. And for those of you I haven't met yet, welcome. We're glad you're here. I also want to take a second to thank the sponsors that Melissa already mentioned, Community Health Plan of Washington and Molina Healthcare, for supporting ICHS Talks. Thank you so much for your ongoing support. We're gathering today because we all recognize the importance of health advocates coming together, especially right now. So thank you for engaging in our central question. What is our role in community health today? During ICHS Talks today, and again on May 22nd, we will introduce you to some thought leaders who are advancing patient care through innovative methods and programs. We're going to share what we're seeing and what we're doing today to make a difference tomorrow. We will show how comprehensive services delivered outside of our clinic doors improve the health of our communities, and identify what health organizations can do today to reimagine what community health can be. But I'll cut to the chase. We know that recent decisions and mandates by the federal administration are putting all of our work at risk. Public health funding cuts, federal funding cuts, they harm us all and our well-being. And especially, they harm our ability to provide healthcare services to those who need it most. But we also know it is within our power to advocate for a healthier future. We may face challenges, but we also have opportunities. Opportunities to reflect on the importance of our health safety net, and opportunities to look ahead. As a nonprofit, federally qualified health center, we provide health services to people of all ages. We're a leader in the movement to expand health access for the most marginalized families, people, and communities. Health centers like ICHS, well, we're innovative, we're healers, we're problem solvers. We reach beyond the walls of the conventional healthcare system to prevent illness. And we address the social drivers that we know can impact overall health. Things like poor diet and nutrition, homelessness, lack of community, or lack of community supports. Many of you know that ICHS was formed over 50 years ago by community activists who were inspired by the struggle for racial justice by Black civil rights leaders. So in our beginning, our mission was devoted to treating underserved Asian immigrants living here in Seattle's Chinatown International District, while we also were interrupting the systemic racism that denied health care to communities of color. And since then, we've expanded to include all marginalized people. So today, ICHS serves over 33,000 patients a year in the Puget Sound area, all backgrounds and identities, regardless of who they are, where they came from, or their ability to pay. So throughout our history here at ICHS, we've known we have to be nimble to adapt to any situation. And in doing so, we've recreated the local healthcare landscape. From developing innovative senior programs to launching services in locations where our patients know and trust, schools, our communities, using our mobile clinics and our pop-up clinics. So we've been opening doors and expanding access and leading changes in health services to ensure that patients get the care they need and deserve. Healthcare leaders have a responsibility to think beyond the needs of their own organizations, institutions, or professions. We must all use our voice, position, and reach to communicate about the systemic challenges we're all facing. We must all do something. I want to thank you again for being here today. I'm deeply grateful that you're stepping into this space with us, and I hope you enjoy today's ICHS Talks conversation. Thank you so much.
Thank you so much, Kelly. That's a great message and a great way to get us started. And speaking of starting, let's go. We are so grateful to our partners at the Washington Association for Community Health. They have agreed to come and share some of their insights on the role of Washington's community health centers today and in this current environment. Courtney and Alyssa, thank you so much for being here, and I will let you both introduce yourselves. Thanks so much.
Great. Thank you so much, Melissa. And thank you also, Kelly, for your words of inspiration as we start talking about some of the challenges that we're seeing in the sort of new day of health policy. My name is Courtney Smith-Jiles. I'm the Chief Strategy Officer at the Washington Association for Community Health, and I'm joined today by my colleague, Alyssa Patrick, who's our Director of Policy Advocacy and Communications at the association with me. For those who might not know the Washington Association for Community Health, we are an organization that represents the 28 federally qualified health centers across the state of Washington. We're the member organization for those health centers. And we support health centers and all of you who are working on behalf of patients in doing everything you can to provide the best care possible for the patients across Washington. Like I said, there are 28 CHCs in Washington, and I will note we'll use the term Community Health Center, CHC, and FQHC interchangeably in our discussion today. But in Washington state, the 28 CHCs actually serve 1.2 million patients across the state of Washington. With that, a little bit of overview of our organization, I would like to kick it over to Alyssa. Feel free to fill in anything I missed on our organization, and you can jump into what we're hearing federally and at the state level.
Yeah, great. Thanks, Courtney. And you can go ahead and go to the next slide. So as Kelly was mentioning, the federal landscape it's been 114 days since the Trump administration took office, and there has been kind of wave after wave of new thing to process and understand how it's impacting our communities and our community health centers. And there's a broad scope of things that have been happening. One of the things that we can do, kind of speaking to Kelly, talking about stepping in where we can from our skills, is that we're hyper focused on what's happening that impacts primary care, behavioral health, and the communities that health centers serve, and dental care as well. So the kind of two main buckets of things that have been happening that the Trump administration has been using to try and implement their agenda is executive orders, which have been just coming out at a rapid pace. And while these executive orders, I feel like we've all been getting a new education in civics, in that an executive order does not immediately become a law. And there are certain things that an executive and administration can do and can't do. And even so, we are seeing that the administration is using every tool available to them to assert their agenda. So while there are some things that have legal questionability, and there are many legal challenges to those things, we know that they are still having real impacts on communities. And some of the areas in particular that we are following is the impacts to federal funding, including changes to federal grant requirements that can happen more on the administrative side and kind of quietly. And we have a lot of federal consultants that are helping track those things and make sure that we're sharing that information with our health centers. The staffing and structure of agencies obviously impacts the funding that is flowing to health centers and different community groups. And then also efforts that impact the care that people can receive and the new regulations going out and that sort of thing. So those are kind of the big buckets of things that we're tracking. And then there's obviously also the federal budget process. So the FY26 budget, which will start in October of this year. We know that that is another place where the administration looks and the majority party looks to assert their priorities. And that budget process has been a rough one and has been really being dragged out. And the desire, one of the big desires that the administration has is to cut taxes, which means a decrease in federal revenue and necessitates significant spending cuts. And since Medicaid is one of the biggest programs that the federal government funds, there are significant cuts threatened to that program. And Courtney and I are actually in DC right now. We're coming back from a trip advocating to our members of Congress, and the Energy and Commerce Committee did just pass a version of a budget that included some levels of cuts, not as deep as it could have been, but still having significant impacts. But there still remains a lot of uncertainty about what can actually happen. That bill has to pass the House, the full House next, and then the Senate also has to make decisions. And there's still a lot of disagreement amongst the majority party on amongst Republicans on what their priorities are. And a lot of that has to do with advocacy as well, which we'll get to a little bit later. But with that, I'm going to kick it over to Courtney, and we can go to the next slide. Oh, actually, I'm going to say a few more things, and then I'm going to kick it to Courtney. Sorry. So what are we hearing? We are, from our health centers, we are hearing and kind of focused on a few major things: Medicaid coverage, gender affirming care, and issues that impact the LGBTQ community, and issues around immigration, and then also tension between diversity, equity, inclusion efforts, and how that might impact federal funding and those sorts of things. And so we know that a lot of the questions that patients have and that community members have about these different issues are reflected in what our community health centers are thinking about and talking about as well. So with that, I will turn it over to Courtney to talk about the community health center perspective.
Yeah, thank you, Alyssa. Before I jump into the CHC perspective, I do just want to add a note or an observation that we saw or had from our time in Washington, D.C. this week. She mentioned an ENC, Energy and Commerce Committee piece of legislation that moved through that committee and passed it, the budget bill. There are very harmful cuts to Medicaid, and that would flow through to health centers in that bill. But I want to note that it appears advocacy is creating tension there. And so we'll talk again about advocacy later, but one of the observations I have from this last week is that we're seeing that friction show up in the committee space and within the majority party, the Republican Party that is leading these efforts, and that division is slowing that process down and making it harder for them to pass some of those cuts. So I just wanted to say, as we're going through this, some of this is hard, but keep that, we have some optimism, cautious optimism that the advocacy is really impacting how that is moving through the legislative bodies and, getting through to members. So again, we'll talk about that later, but I didn't want to miss sharing that observation before we moved on to a little bit more about what we're hearing at the CHC level. So as Alyssa said, what patients are thinking, the questions they may have when they show up into the four walls of a medical office or a clinic, we know you all are thinking about, well, then how do you answer those questions for your patients? And how do you answer that for how you deliver care to your patients? one of the benefits of my job at the Washington Association is that I get to hear from and talk with all 28 members across the state. And what I can tell you is that the answers haven't been found yet to some of the issues that Alyssa raised. Health centers really are grappling with how do you continue to provide care? What is the approach to providing gender affirming services or caring for your patients who may have those needs, or supporting access to healthcare for those who may be non-citizens? There's a lot of discussion about how to do that in a way that is compliant with the laws that we all operate in and ensures that federal funding is not risked, but there's no clear answer or pathway. And I would offer that it does feel as though we are still grappling with that as an entire system. So while there are no answers, what I am hearing and what I am seeing within our community health centers is a deep commitment to mission and a deep commitment to working with consumer boards, their consumer boards, to make sure that however they choose to navigate these big questions about care delivery and serving your patient populations, I'm seeing folks really dedicated to their mission, making sure that they can serve patients and continue to do that hard work that you all do day in and day out. In addition to that, I will say that I am seeing kind of a range of perspective on how those changes might happen. We see some folks sort of doubling down on certain types of services, and then some folks who have concerns about how that may impact their ability to keep their doors open and continue serving all of their patients. So we're seeing a range of approaches in the wake and in the face of these federal threats. But again, I feel really heartened by seeing our health centers really connecting to their mission and working with their community boards to address those matters. What we're hearing nationally too is very consistent. So we were lucky to be with several primary care associations who work with their own state or CHCs across their states. And we heard similar themes. So no clear pathway yet on how to address this, or no clear consensus within the community health center community about how to address and light the way forward. But really folks are grappling with it and have a wide approach within each individual state as well. So interesting to sort of see that at the state level, we're all sort of in the same place as 114 days after Trump was inaugurated. We're still sort of getting our footing, trying to figure out what the next steps are. One thing I will say is that we are also working with our national partners to seek legal counsel and to understand what the legal questions and what is legally allowable in the wake of some of these big changes where we may not know how it will be implemented. And so I feel very grateful that we're connected to those partners to seek some of that input. And over the next few weeks, we actually expect to get some clarification on matters around DEI, grant drawdowns, and things of that nature. I will at this point kick it over to Alyssa because we can talk all day about what we're hearing, but that doesn't help us necessarily act if we're just talking about what we're hearing. So Alyssa, can you talk a little bit about what action folks can take if they're so inspired?
Yes, yeah. So a few points we wanted to make here is that advocacy really is working, and coalition building, and we're seeing so many different groups come together around shared interests of people being able to take care of themselves and to be valued as people. And so we know that while we have seen some Medicaid cuts introduced, they are the tensions that have been created and what actually ended up getting introduced at this point are a direct result of the level of advocacy that is happening from so many different groups. People that voted for Republicans are advocating for protecting Medicaid. Hospitals and primary care providers and labor unions are working together on advocacy. So, and that needs to keep happening, and we know it will keep happening. And as health centers have come from the civil rights movement, as Kelli mentioned, that's a deep part of where we are rooted. And I'll have some resources on the next slide when you get these that you can go to advocate specifically for community health centers and then for Medicaid as well. And then just coming back to the health center mission as well. Health centers are always going to serve everyone. They're committed to affordability. They are led by patients on their boards and are accountable to their communities. So and they've weathered difficult storms before. Health centers have. And they, finding innovative business practices is um, one of their key goals as well. And so as we're having to navigate the realities of some of the things that have to be responded to right now, we know that health centers are finding different ways to serve their patients and comply and stay open. So, and some of that comes from taking a breath there's so much coming at us. There's wave after wave, but it is important to, when new information is coming out, take a breath, sit with it, and go to your trusted resources to understand, what the real impacts are of those things. So we included some more resources here where you can sign up for advocacy at the state level and nationally, learn more about health centers in the state beyond ICHS, and then also some recommended news sources that for in this space.
And as we come to a close, I want to really reiterate what Alyssa said about pausing and taking a breath. We can see the path ahead more clearly when we do that. And I also want to thank you all on this call, particularly those who work directly with patients. It is an incredibly challenging time, and I know that many patients are scared, and I just want to say thank you. Keep doing what you're doing. We are going to walk this walk one step at a time, and we can't do it without you. So deeply appreciate your commitment to serving patients and your own communities, and appreciate the opportunity to be here today.
Thank you so much. We are so grateful to have you both here and offering this perspective. And I want everyone to remember that they are also both back next week for part 2 to talk more about what's happening. And it's really a perfect segue to talk about kind of the stress and how we need to breathe and all of those things that we now switch to our Behavioral Health Services Director, Kate McIntyre. Kate is just a wonderful resource. She is going to talk about the stigma around behavioral health because we are seeing the heavier impacts on our populations right now. So I'm just going to get out of the way. Kate, welcome. Thank you so much for being here.
Good afternoon. Thank you so much for having me. I want to thank everyone for joining this session today for this very important topic. My name is Kate McIntyre. I use she, her pronouns. I am a licensed independent clinical social worker, and I also have a master's in public health. I have the pleasure of being the Behavioral Health Services Director here at ICHS. And prior to my experience at ICHS, I have over 16 years experience in behavioral health settings, all in community health settings, so in federally qualified health centers, in community mental health, in residential. And so what all of that really means is community health is a part of my heart and the work that I've been doing this entire time. This picture is from COVID, when we first got the COVID vaccine. It was a very impactful time in a lot of different ways. It was exciting to have a vaccine and be able to provide that to our staff. But for the behavioral health world, COVID really brought a lot of things to light. And so I'm going to talk a little bit about that in a minute. Next slide. First, I want to talk about the role of behavioral health in a community health setting. It is very important to have behavioral health services in a primary care setting. We can really make a large impact and a positive impact on some of our most vulnerable people, our community members, our patients, by being integrated into these community health settings and also into our school-based health centers. We can really break down barriers to accessing care if we're in the same hallways, in the same areas as our primary care doctors and our dentists. And being in those settings also means that we can treat more people that might not want to go to a mental health or a substance use disorder treatment center or facility because of stigma or because of a lot of other reasons. We can see those folks in the primary care setting and also in our school-based health centers. And we can also support our primary care providers to better serve patients because we have specialized training in these areas that they might not have had training in. And so we can support them by being available to them. And this picture is from our Seattle World School. It's from our school-based health center here in Seattle. And I'm going to talk a little bit about the role of school-based health centers in a minute. So first, you might be wondering, what is behavioral health? It's an overarching term that we use to talk about mental health, to talk about substance use, and just overall well-being. You can see in the picture here, what we're really interested in is all aspects of your health, your social, emotional learning, how you're doing in your environment, how your physical health is, if you want to be working. So all of that is a part of your whole person health, and behavioral health is actually a large part of that, and the way that you feel about yourself can impact your overall health. In terms of who needs behavioral health, the answer is everyone. It's me, it's everyone on this call. Everyone has events that impact them. So people have stress at work, they have stress at home, they hold stress in their body. It's a very stressful time right now, as you heard about previously. And chronic physical health conditions can also have an impact on your behavioral health. And I also want to make a special call out for people of color. They have more barriers finding providers of a similar background and culture that can really help understand where they came from and had similar experiences. And all of this impacts who gets services, and how they get services. So if everyone on this call today just thinks a little bit about behavioral health and themselves, have you ever had a moment where you felt stressed, sad, overwhelmed, anxious, or angry? That's your behavioral health. And think about, what did you do when you felt those emotions? Was there someone that you could reach out to or talk to? And did it help to do that? For some of you on the call today, the answer might be clear. You had access, you had someone to speak to, and it was helpful. For other people, you may have experienced other barriers. It may have been hard to get to services, or you couldn't find someone that you could really relate to that had a similar background. So again, this really impacts everyone, and who gets services and how they get services. In terms of the specific need in King County, you can really see from this graph that adults in King County are really struggling. What this study looked at, was measuring what's called frequent mental distress. And just so we're all kind of on the same page about that, that is people who are reporting 14 or more days in a month of having poor mental health. So even if you look at the overall number and you think, oh, 12.9, 13% is not a ton, that means that 13% of just King County adults, the study was from 2017 to 2021, for more than half the month are having a really hard time with their mental health. They're really struggling. In terms of substance use, we also see that adults in King County are struggling. In this study, it was from 2015 to 2024, and it looked at overdose deaths, and it separated out the data by race and ethnicity. And so American Indians and Black Americans had the most struggles with overdose deaths in King County. So you can really see from all the different lines that folks struggle differently based on their background, the resources that they have. And even though you see a pretty big dip from 2023 to 2024, we know from watching the news, from hearing other stories, that folks are really struggling in King County with substance use, especially fentanyl. We know it's a problem, and we know that it is killing people. Our youth are also struggling. What we see in our school-based health centers and in our clinics is that our kiddos are struggling with loneliness, with isolation, with fear and anxiety. And then in King County specifically, 38% of our youth, which is defined from birth all the way up to age 25, who have a Medicaid benefit and a mental health need, did not get mental health services. So this means that 1 in 4 of our youth here in King County have experienced depression, and that number only increases if they identify as part of the LGBTQ plus community. So we know, again, that adults are struggling and youth are really struggling in King County. And as I mentioned previously, the COVID-19 pandemic really highlighted the behavioral health crisis in the United States, really everywhere, but it highlighted it for everyone, and especially for our youth that were most of the time at home and isolated. We saw during this period and afterwards that requests for services for behavioral health really far outnumbered the number of providers. And so access to services to behavioral health became an even greater challenge for the behavioral health field and for folks that were reaching out for help. So at this point in the talk, you might be thinking, this is very depressing. So I want to pivot and talk about what we're doing to help address some of this and what behavioral health really looks like at ICHS and try to lift everybody's spirits a little bit. So in terms of behavioral health services here at ICHS, we can do screening, assessment, and diagnosis. We also do a lot of prevention work, which looks like early screening and intervention. And then, of course, we provide treatment. We teach skills, work on building or changing habits, recognizing patterns, how people respond, processing events. Treatment looks very different for everyone. And we can also provide referrals to more intensive or longer term, more traditional kind of outpatient behavioral services if needed. We try to do as much as we can for folks in-house, but if somebody needs a little bit more specialized work, we can also refer out. And little tidbit of information, wonder how many folks it would surprise on the call. In our primary care settings, our behavioral health team can also work with physical health diagnoses, not just behavioral health. So if you remember from a little bit earlier, I was talking about how you feel in your body, how you feel in your mind is all connected. If you think about somebody that has just gotten a first-time diabetes diagnosis, we can really work with them in the primary care setting on how they're feeling about it, if they want to make an action plan to change their behavior. We can work with those folks, not just people that are looking for mental health or substance use disorder treatment. So we can really help kind of a wide variety of folks in the primary care setting. One thing I always like to call out is level of care is very important. And this is why we want to make sure access is so available in the primary care setting. So we see a lot of patients in primary care, and we want to be able to get people in as quickly as possible, because as you move up this spectrum, the longer people need to work with folks and the more interventions they need to have usually means the less access. So what you see here in the yellow, specialty care, is really that traditional kind of outpatient long-term therapy that folks are usually more familiar with. Usually in King County, places can be booked out 2 months or even more to get services. To get residential treatment, which is much more intensive, you live in that facility, it could take years to get in there. So we want to think about our role in this green area in primary care. If we're booked out and the yellow is booked out and the red is booked out, that means that patients are going to the emergency room or to inpatient treatment for care that we can really provide in the community setting. And so that's why access is such a huge focus for us in this primary care green area, because we want to get as many people as possible. So just a few more pieces of information about behavioral health in a primary care setting. We do allow for same-day access. Again, thinking through if someone has gone through the step of saying, I need some help or I want some help, we want to be able to say, great, we could get you in today. We don't want to say, we'll see you in 3 months, because that does not feel good to hear, especially when you are struggling with something. We're also a part of the treatment team with the doctors. So we work in that team-based care model. We work on the same treatment plans, and we keep in communication about everything that's going on. Again, we can do treatment for anything that can be helped for a behavior change, not just a mental health or a substance use diagnosis, although we certainly love working with those folks. We can also help people with physical health. And then again, like primary care providers, we can work with a wide variety of concerns. This is a picture of our Highland Middle School up in Bellevue, and on the right-hand side is our mental health therapist's office. So again, I just want to highlight, by being in the clinics and by being in the schools, we can really break down some of those access barriers so that parents or caregivers don't have to think about taking off time to transport someone to services. We can just see them right there in the school, and again, get folks that may not traditionally be seeking services. And now I want to talk a little bit about stigma, just so we're all on the same page. Stigma is really negative attitudes, beliefs, or behaviors, and in this setting, really specific towards behavioral health services. So we can all probably think of some negative stereotypes, what discrimination looks like, prejudice, and of course, self-stigma, what you believe about yourself and what you've internalized. And stigma is one of the main reasons that people don't get behavioral health services. If you think about it a little bit like this, we don't really treat behavioral health like physical health. It's very kind of, quote, normal to go to the doctor for a rash, but it is not yet normalized, especially in the United States, to see a therapist when you're sad. And so why is that? It is stigma. And where does stigma come from? A lot of times it comes from your culture, especially in the United States. A lot of us are not coming from cultures where going to see a therapist or a substance use disorder counselor is something that is prioritized or honored. Can also be impacted by your parents or your caregivers, the people that raise you, the way they feel about mental health and the way their caregivers passed it down. It's also the way your beliefs impact you and again, your family and friends. And then also the media. This is a picture from one of my favorite Korean dramas, It's Okay, That's Love. It's an amazing movie, but it does have a pretty negative impact on folks because of the way that someone with schizophrenia is portrayed. And so if you see someone in the media that looks like you and is portrayed really negatively, it's going to impact you getting services. So again, the way that ICHS is trying to impact stigma towards behavioral health, we're in the same setting as our primary care providers. We have lots of culturally specific providers that understand the background and the experience of our very diverse patient population and speak their language. The services are also a little bit shorter, like primary care visits, so it feels more comfortable if you've never had that type of treatment before. And again, I just want to show a picture from our Shoreline clinic. We hire very diverse staff on our behavioral health team. We have folks that speak English, Mandarin, Cantonese, Vietnamese, and Korean. And our patients speak over 70 languages, so we try to hire very diverse team members that can really understand, the impact and the culture of where our patients came from. Couple of last points I want to leave you with. I personally saw a patient that was 17 years old, dropped off by his mom for sinus issues. We screened for depression in visits, and this individual scored very high, but didn't want to talk about that with the primary care provider. So she said, "Hey, will you come in and meet this guy?" I met him. We discussed the way that he was feeling. He was very depressed. He was very impacted by the way his family viewed his mental health. And so we were able to start services that day. And so my question to all of you to think about is, would he have gotten behavioral health services somewhere else if we were not in that primary care setting? Probably not. To wrap up here, I want to emphasize that ICHS is very committed to behavioral health and we want to do more. We are opening what we call a little bit higher level of care, our long-term kind of mental health services later this year. This is our beautiful Shoreline Clinic and we'll be up on the 3rd floor. And so stay tuned on our social media and our website for when we open there. And then I just want to close out by letting everyone know that May is Mental Health Awareness Month. If you're not familiar with the National Alliance on Mental Illness, they have a great campaign also trying to break stigma by having people share their stories. And so my call to action for all of you today on the call, again, thank you for being here, but the way you can really impact stigma is ask questions of people in your life and listen to their responses that will help them see that it's okay to talk about mental health with you. So I've left you with some questions here to think about, and my call to action for all of you is to really talk to someone in your life, ask one of these questions based on your relationship, listen to the answer, because the best way we can really break the stigma against getting behavioral health services is to talk about it.
Amazing. Thank you, Kate. That was so informative for me. I think a lot of us know we do behavioral health, but I'm not sure a lot of people really understand how that process works as we work through having everything co-located. So really interesting. Thank you so much. Such an important topic. And last but certainly not least, I want to introduce the amazing Cheryl Gray. She is the ICHS Director of Community Health Services, and she is the person who really gets out in the community and takes on a lot of this stuff head on. She and her team are remarkable. Rosalie's going to join her, I think, and they're going to talk about school-based stuff and just some of the really cool things that we're doing. So I'm going to let Cheryl take it from here. Welcome, Cheryl. Thanks for coming today.
Thanks, Melissa. So I am going to wrap up this first ICHS Talks session by talking about guiding patients through the healthcare maze. And so one of the ways we do that is with the support of that amazing team that Melissa was referring to that I have the privilege of overseeing, and that's our community health services folks, which includes our community outreach and engagement team. You can see their picture up there on the right is an example of them out in the community. Our patient navigators who work in the clinics to help our patients get the services that they need. We have a team that is dedicated to just helping people enroll in insurance. And then we have what I refer to as our non-traditional access points, which is really just us bringing care out to the community. So that does include our school-based clinics, which we operate in partnership with our clinical teams, like Kate, who oversees our behavioral health team in this. I just blipped out. My screen just went blank. So I hope I'm back on. Going to the next slide, I'm gonna kind of just hone in on each of those teams. I would have loved to have somebody from each of our programs come and talk about the work that they're actually doing firsthand, but I was able to kind of talk Rosalie into coming. So I want to make sure that I get through my portion and give her time to highlight the work that she's doing. But to start this talk, I just want to talk about, like, to even get into the healthcare maze can be a challenge for a lot of folks. And so that's where our community access team comes in. And there's a picture here of one of our great community access specialists, Sabina. And one of the things that Sabina and her colleagues do is partner with other organizations like HopeLink or Goodwill or the library to just be present in the community to talk about ICHS and primary care, but also just to help connect them to other resources that they might need. And one story that really exemplifies this is, Sabina was out in the community tabling at HopeLink, which helps with various social service needs in the communities that we serve. And she met a mom who had recently moved to the area. She had her and her kids didn't have connection to primary care. School was going to be starting. Vaccines were due, that sort of thing. Sabina helped her get enrolled in, her and her kids get enrolled in insurance. She helped her get an appointment at ICHS. She met her at the clinic just to make sure that things went okay that day, and that if there was any challenges with paperwork, Sabina speaks Russian, and so she's often able to help our Russian-speaking community members navigate some of the challenges that come when we don't speak the language of those folks at the front desk. So she helped her get all set up, get the kids in for their appointment, get them their vaccines before school started. And so that's just one example of how just getting into the healthcare maze can be helped by just having somebody there to help guide you through it. Our enrollment specialists, they are our award-winning team for King County. They have enrolled so many folks in both qualified health plans here in Washington and also Medicaid. And one of the things that I think is sometimes a little hard for folks to wrap their head around, if you're somebody who has just had kind of consistent medical insurance, maybe through your employer, is how each year for some folks, especially those on qualified health plans, circumstances might change, their financial circumstances or their medical priority. And so they really need somebody who can help them find the best plan every year. And we are so lucky that some of the folks on our team have been here since the Affordable Care Act was enacted. And so they really have a deep knowledge of all the new plans, the changes in the plans, and they can really help folks navigate through that. Our team is there to help the community and ICHS patients. We will support whoever needs us. And I just wanted to share an example. We can go back just to that slide really quick, because I want to talk really quick about one of the great stories that one of my team members shared with me, where they had been working with a woman since she had moved to the area. She initially came, they helped her get set up with a qualified health plan that she could afford. She then got a job, which changed her financial situation, but she still needed a qualified health plan. So they helped her find one that worked for her that she could still afford. A couple years later, she unfortunately lost her job. And so then again, they were able to help her. And at that point, she would qualify for Medicaid. So they helped her get enrolled in Apple Health. And a couple years later, she gave our team member a call just to let her know how much she'd appreciated all of her support through the years, and to let her know that she was now transitioning to Medicare. And so she was going to be not needing those resources from her over the years. But that's just an example of how having folks in the community connecting. Again, our team, as Kate was saying, we have a diverse team. This team speaks Chinese and Vietnamese, and we have folks that speak Spanish and Russian and Amharic as well that are helping with insurance enrollment. So next slide, thanks. Moving on to our team that's helping folks with what I described as those non-traditional access points. One example of that is our mobile dental clinic. And our mobile dental clinic, we partner specifically with schools to help support students who have barriers to getting dental care. What we know is that oftentimes, especially lower income students, those who are on Medicaid, even though they're insured, they access dental care at a lower rate than their peers, and they tend to have more dental cavities, basically. And so when we go out to the school, we reduce those barriers by we're right there. Parents don't have to take time off work to get their kid to and from. Their student can be back in class within the hour. And what we find is that a lot of our students, if we weren't there, every other week and making sure that they got access to those appointments, they really struggle to complete their treatment plans. So when we do identify a need for restorative care, it's just much easier to make sure that gets taken care of when you're right there with the student. And we also have, I don't think I have a picture, but we also have a mobile health unit that has been, we've had for about the last year. And one of the things that we've noticed about our mobile health is that while we had initially deployed it sort of to help with access of our patients who were living in South King County and had to travel a great distance to get to what's usually our Holly Park clinic, what we found is that just by being present in the community, people were just walking up and saying, hey, can I get care here? And so we would have those walk up new patients. And it just demonstrates that sometimes the best way to break down those barriers is to get into the community. I'm going to go ahead and we can skip. Well, we also have these pop-up clinics that we do, which has been helpful, especially for our seniors in the area. I'm kind of rushing because I want to make sure I leave time for Rosalie. And the last group that I want to speak about is our patient navigators who work in our clinics, and they help support our patients with accessing services related to social determinants of health or health-related social needs. The top 5 things that this team helps with are transportation, housing, food access, our healthy aging and wellness program, which includes support for caregivers, and then cash benefits and assistance. And again, this is a multilingual team. They are given referrals both directly from the patient through surveys and then also through the providers that see them. And now I want to hand it off to Rosalie because she's going to talk about how the school-based team sort of helps people just kind of avoid the maze altogether.
Hi, Cheryl. Thank you. Well, my name is Rosalie. I'm the clinic care coordinator for the Highland Health Center. I've been working at this location since the beginning. It's the first and only school-based health center in Bellevue School District. I'm certified medical interpreter and document translation. I'm an immigrant myself. I was born and raised in Venezuela, moved to the US in 2016, and I've been working for ICHS in 2017. Kind of fun fact, my son, when we just came here, he was in Seattle World School. So he benefited from the school-based health center there. And well, I ended up working here, and I really appreciate the work and the access that it provides and the safety net that it could be for folks that are just getting in here. So we have seen so far that the healthcare seems like a little bit tricky. It's hard to navigate. But I'm also here to tell you that there is an easier way, or easy access. Could you please? go to the next slide, please. Okay, so for in this case, the school-based health center clinics serve like a one-stop shop for our patients and families. So we receive referrals from different partners from the school, from communities, social workers. People just stop by and ask, "What is this? Can I have access?" In the case of Seattle, in the case of Bellevue School District for Highland Health Center, we're able to see any student that is enrolled in the district. So that means that our patients come from like anything 6 years old up to 20, depending on how when they graduate and all of that. And the beauty of our system or our clinics is that we're able to accommodate our processes and allow access, where sometimes clinics can be a little bit first more scaring and maybe not as comprehensive as we can do. So for example, for referrals, we have a dedicated site in the website for the school. They can do DocuSign registration. We have paper forms for people that have literacy issues. We can help them with the registration right there. We have the interpretation services on the phone. The online platforms, people can reach us, students can reach us through Teams because we're integrated in the school. We have simplified registration, as I mentioned. Everything we can do through DocuSign, immunization consents, we have level consents to see them with their parents once we have like the registration through. We offer after school appointments on Wednesday. There is early release. And in our location, we have a free medical provider, actually. We have a pediatrician that comes every other week. We have a regular PCP, the physician assistant that is available 3 days a week. And we have a Monday through Friday BH provider that is very integrated with the counselors in the school and also with the different partners. So the warm-off is really easy to make. We also receive the visit of our MDC team. They come once or twice a month. And we actually serve like a pathway to get established in care. It could be with ICHS directly or any other organization that our clients feel more comfortable going to. I have a community health worker that helps me do all of this follow-up and connecting our patients to care. What else? One of the advantages is that most of the times we build a relationship that lasts years. So maybe we get some of students start here in 6th grade, and then we continue to see them even when they transfer to high school. And because we provide advanced consent from the parents, even if they cannot bring them, if they're able to take the bus or they're able to get to us, we can see them without having the extra barrier of, if your parent is not here, we cannot see you. And we also are able to work with the PCP. If someone has already a PCP established, if we will help them connect with a PCP, our providers can coordinate care with them. We all know that sometimes it's very difficult to establish care. It can be months before you have your first appointment. In the meantime, we can bridge the gap for those folks. Can you please do the following slide? So what you see here is one of our patients, the parents of one of our patients that had 2 kids at the school. And it's really interesting because when I was prepping for this presentation, he just out of the blue sent me this message. I helped him a few months ago with insurance because we can do also that. We are all certified navigators, the community health worker and me. And he wanted to thank me because apparently he had been suffering from something for 5 years. And since he didn't have access to insurance, he couldn't take care of that. And then this father also, we had kind of like a bumpy start with one of the kids where they were afraid of needles. There was all of these things where at the beginning maybe
the kid was afraid to come back to us, but we were able to work with the family to the point that this kid participated in a summer camp that we offered during summer. They also finally got their vaccines done at the clinic. So it was like a comprehensive system. They got medical, dental care as well. And our providers also have been able to help other patients that needed diagnosis for ADHD or ASD or OCD and work with the PCP directly to get them diagnosed in a record time, even 3 weeks. Sometimes that's hard to do when you don't have integrated care. I also wanted to say that whenever our capacity is limited, I know that I can always have the support of my team. So sometimes if I know language is going to be a barrier and my family are going to be comfortable with someone that speaks their language, then I can refer them for insurance with the team that does that. I have worked with Sabina a lot of times. I had a mother came in with a baby, so we cannot see babies at our location, but I was able to let her know, okay, you just arrived to the country, you don't have insurance, I'm going to send this message. You can, it's a lot of education también. Sorry, I have my mix with the language. It's a lot of education because people come from countries where they don't have this idea of what is a PCP. And then they don't know the importance of having a PCP. So one of the things that I do when I first meet them is try to assess how much they know so I can help them provide the services that they actually need. And one of these things is, do you know how many levels of cares are in the US? If you feel this way, you know where to go. So what do we do in primary care? When do you need to go to an urgent care? How does that look like? If you don't have insurance, do you know that you have options to apply for financial help? So it's all of those things and responding all of those questions that our patients heard. Sorry, and I think we're over time.
I know there's so much to share, and I wish you could go on because the work you do is phenomenal, but I think we're at the end of our time. So I wanted to thank you so much for accepting my invitation to join and share all the great work you guys are doing. Thank you so much.
Thank you.
Oh, thank you so much, Cheryl. Spot on. We could just listen to all of this information all day, but absolutely awesome content. And we are at the end of our hour, and we want to keep it on time. So we are going to send out a survey link. It's going to be in the chat. We'll also send it out after. Please fill it out. There's a spot there to ask additional questions. We did not have Q&A time today, but we'll do our best to address any questions you send by next week. I really, really want to take a moment to thank our presenters, both from within and without the organization. I want to thank the foundation team who worked incredibly hard to pull this together and really tested some new muscles and really, really couldn't be more proud of the work they've done. I want to thank our sponsors, Community Health Plan of Washington and Molina. And, thank you. Please share your feedback with us. We want this to be the start of something really helpful for our community. So with that, we release you to the rest of your day with great gratitude and appreciation. And I hope we see you next week. Thank you so much.